Hi, hello, welcome to everyone who's joined our webinar. I think we will get started. We have a lot of really interesting content today. We've already done the housekeeping for those that joined a few minutes late, so you can find all of that information in the chat in case you get stuck. So our webinar today is our second webinar in our Data to Action series, and the theme today is on informing menstrual health management programs. Today's event is organized by the Population Council's Girl Innovation Research and Learning Center, or the Girl Center, and EGER, the Evidence for Gender and Education resource. And today we are partnering with ZanaAfrica. I'm Karen, Austrian. I am the director of the Girl Center based in Nairobi, Kenya, and it's my pleasure to host today's webinar, joined by colleagues and partners that have been working to find evidence on what works for girls in menstrual health management, and doing the real hard work of translating this to programs that improve the lives of adolescent girls. So, I think about adolescence as really a period of time that is characterized by a series of key transitions for girls, and they're transitioning in this way from becoming girls to young women, but it's actually a series of very rapid transitions. Moving from primary school to secondary school, completing secondary school, dropping out of school, sexual debut, their first romantic relationships, becoming a wife, becoming a mother, not always in that order. And these are not always linear transitions. And when we think also about all of these transitions, the beginning of menstruation is also a key transition for adolescent girls. In addition, it's often accompanied with a time where girls start getting more noticed in her community. She gets attention that maybe a young woman might get as opposed to a child. So sometimes this comes with privileges, and often this comes with risks. And so, as is central to the mission of the Girl Center, we want to use data and evidence to better understand the impact of MHM programs, menstrual health management programs, to really understand how best to position these programs in the broader context of adolescent girls' lives, and really overall to talk about and to really engage on and to support practitioners around what is the best way to support girls through these myriad of transitions, and in particular, the transition of starting menstruation. So in our event today, we will first hear presentations from Population Council's researchers sharing the latest evidence on this topic. So we have Nicole Haberland, who's a senior associate at the Population Council based in New York, and she will be sharing evidence from a global systematic review on menstrual health management programs. Then we will hear from Dr. Beth Kangwana, who is the Executive Director of Population Council Kenya, and she will be presenting results from a randomized control trial in Kenya that evaluated a menstrual health management program, the NIA project, which was implemented in partnership with ZanaAfrica. After those two presentations, we'll have a short Q&A session for any questions that you may have about the two presentations. So feel free, as you're listening to the presentations, if questions come up, please just include those in the Q&A function, and then we will get to them when we do take that Q&A break. After that, we'll move to a conversation between me and Megan White Mukuria, who is the founder of ZanaAfrica, also based here in Nairobi, and we'll have a chat about program implementation and how evidence and the results of these studies have been shaping ZanaAfrica's approach. During this conversation, we'll also devote time to asking questions of Megan from the audience. So again, whenever you have a question, please just put it in the Q&A function, and then we will be collating those and passing them on to our speakers. So without further ado, let's get started, and I pass the floor over to Nicole Haberland.
Hi, everyone. Sorry about that. I think I get the hang of this after years now. Thank you all for coming. I'm going to share with you a systematic review that we conducted examining whether provision of menstrual health supplies improves education outcomes for girls. So a brief background to the study. Good news. We've seen a dramatic increase in girls' enrollment globally. Data globally, gender parity has been achieved in primary and secondary enrollment. The not so good news is that there's been extended learning disruptions due to epidemics, environmental disasters, and conflict. There's gender gaps in enrollment and attainment. Progress in attainment has stagnated, and there are shockingly low levels of learning. Continue to face ongoing conflict with schooling and adulthood. So despite remarkable gain in girls' education over the past decade, striking gender disparities persist. And this is true especially if we take an intersectional lens. Poorest girls, they have the lowest attainment, the worst learning outcomes, and the biggest gender gaps. Terribly. Next slide, please. So why is that? A number of reasons. But a set of them are gender-related barriers to schooling that are present at the community, school, and household levels, such as child marriage, insufficient academic support, school fees. One of the barriers that arises in the discourse is inadequate menstrual health supplies. This is hypothesized to affect education through, for example, increased absenteeism. So, next slide, please. So we set out to find what works to address these barriers. And the full review, all 18 barriers, was just published in Campbell Systematic Reviews. And the paper is open access, so we'll share the link. Slide. For the full review, we did an extensive search of multiple places, websites of relevant organizations. We reviewed biographies, reached out to authors, experts. We included randomized trials and quasi-experimental designs that attempted to control for studies or data had to come from low and middle. Did peer-reviewed journal article, grade literature. This had to be published in 2000 or after. Analyses had to measure the effects on educational attainment, learning outcomes, and of course the intervention or exposure had to address a gender-related school. Reviewers independently screened for relevance, extracted data, and assessed their bias. We were unable to conduct meta-analyses due to lack of comparable results across studies. So we use the grade approach to synthesize data. We identified 26,000 papers, which we narrowed down to 88 papers, presenting results from 82 studies for the full systematic review. Of those, 4 studies in 6 papers evaluated the effects of interventions that address menstrual health. So what did we find about menstrual health supply programs? The 4 studies all employed an experimental design. They were conducted in Kenya, Nepal, and Zimbabwe. One provided menstrual cups, another provided sanitary pads, one provided training on how to make reusable sanitary pads, and the last one was a multi-component program. It included sanitary pad distribution, payment of school fees, uniforms, school supplies. So while 3 studies directly assessed the effects of MHM interventions and all reported a significant effect in the expected direction for at least one outcome. However, effect sizes were predominantly small, null, concerns about risk of bias in nutrition were a significant issue to the studies. Slide. You can see the effect sizes visually here. Most confidence intervals crossing 0. So there was not sufficient quantitative evidence linking menstrual health supplies to education outcomes. And we think that more research is needed to assess the effects of interventions that address menstrual health supplies outcomes, especially given the increased attention it is garnering these days from advocates and policymakers. Stay there. There are, back, sorry. There are other, we should keep in mind there are other reasons apart from education outcomes in the world why provision of menstrual health supplies may be desirable, such as dignity, confidence, reproductive health knowledge. These are testable questions. But given increasingly challenging circumstances and communities, those responsible for making decisions about limited education budgets need accurate information about costs and benefits of the different interventions under consideration. So included more research is needed, and so we're really eager to hear what Beth is going to be presenting in ZanaAfrica's experience. Next slide. Please check out our website where you can find the latest evidence on what works in gender and education, and search and discover hundreds of organizations and programs doing amazing work. Join us on EGERresearch.org. Thank you so much, and back to you, Karen.
Thank you, Nicole. That was a huge amount of work summed up in a very few minutes. Couple of minutes, and I think, you know, the conclusions pointing that we don't have a strong enough evidence base makes this next presentation even more necessary, and the work that it undertook. So I'm really excited to turn the stage over to Beth Kangwana from Population Council Kenya.
Hello, everyone. So I'll be presenting on the impacts of sanitary pad distribution and reproductive health education on education and sexual health outcomes. And this is a cluster randomized controlled trial. Next slide, please. So as a form of background, the onset of puberty and menarche is an especially vulnerable time for girls, as Karen was alluding to. This is a time during which the girls begin to show interest in the opposite sex while becoming exposed to a myriad of external pressures, including sexual coercion or harassment from boys and men, expectations to marry from their families, and also the need to perform well in primary school in order to qualify for secondary school. According to several qualitative studies in Africa, we see that such pressures are exacerbated by girls' lack of knowledge of their bodies, their rights, and the implications of their decisions, and by their inability to manage puberty and adolescence safely and comfortably, while with appropriate menstrual health and hygiene management products. We reviewed, at this time, the study was being carried out, several qualitative studies which had been conducted in Kenya that identified a range of challenges girls face in managing their menstruation, which includes a lack of access to menstrual products and also a lack of accurate information about menstruation. Next slide, please. So the review led us to a research question, which we're trying to answer, which was, what is the effect of sanitary pad distribution and reproductive health education on girls' health, well-being, and education, each on their own and also combined? The study we carried out was a longitudinal cluster randomized controlled trial, where we had 140 public primary schools that were in 3 rural sub-counties, randomly selected and stratified across these sub-counties. So we put each of the schools in 4 different arms. So in the first arm, we had 35 schools that received no intervention at all. That was the control arm. In the second arm, we had 35 schools that received a sanitary pad distribution. In the third arm, we had 35 schools that received only reproductive health education. And then finally, in the fourth arm, we had 35 schools that received a combination of both sanitary pad distribution and reproductive health education. The study itself took place with girls who were in grade 7 at baseline in primary school. And in schools where there were 25 girls in grade 7, all girls were included in the research sample. However, in schools which had a larger number of girls in grade 7, 25 girls were then randomly selected for each for the research sample, and we added an additional 5 girls just to buffer up the numbers. Next slide, please. In terms of the intervention, for the NEAR project, each girl received 1 packet of 10 disposable sanitary pads each month of ZanaAfrica's NEAR Teen brand for the entire project period. Lack of underwear was identified as a barrier to pad usage during the formative assessment. Therefore, the project beneficiaries were also supplied with 2 pairs of underwear at the start of the intervention and an additional pair at the end of each subsequent term. So the NEAR project reproductive health education intervention was comprised of facilitated health education sessions that were led by a mentor. And also there was the NEAR Year 2 Health magazine, which was developed by ZanaAfrica. And both components were informed by the UNESCO International Technical Guidance on Sexual and Reproductive Health Education. So we had 25 session curricula that was delivered by the trained mentors or facilitators during weekly girls-only health clubs. And the study itself was carried out, or these health clubs were carried out in 2017. And then in 2018, the health clubs then turned into bi-monthly sessions. And these were held during the time that was allocated during the extracurricular activities in school. Next slide, please. So what we did is we then developed a research design around the intervention. We collected baseline data in 2017. So we were able to collect data on 3,489 girls who were in class 7, and the mean age was around 14 years. We also collected school quality data using a school quality survey, and this data included access to wash facilities and also information on school characteristics. In addition, we collected school attendance data for 20 consecutive days in term 3 in 2017. So there are 3 terms in a year. And so we collected data in term 3 in 2017, and then as the girls moved to class 8, we collected school attendance data for term 1 and term 2 for the following year. And then finally at end line, after the end of the intervention, we then went back to the girls and were able to successfully follow up 94% of them and re-interview them to see if there were any changes. Next slide, please. In terms of the end line results, what we saw, so the first indicator we measured was management of menstruation. So we looked at the percentage of girls who reported having enough pads. So here is a bar chart, and what we see is the green bar is the control arm, the blue bar is the combined pads and reproductive health. The gray bar is the pads only, and the orange bar is the reproductive health only arm. And we saw that, although this is not shown in this graph, that at baseline, only 20% of girls across the arms reported having enough pads. But at the end of the study, at end line, we saw that up to just above 80% of girls in the arms that were receiving the NEAR pads, so the combined arm and the pads only arm, were reported having enough pads. We also saw a significant 20 percentage point reduction in girls reporting leaking in the combined and pads-only arm. Next slide, please. We looked at norms and attitudes, and here are bar charts that show the difference in outcomes between baseline and endline. So the bar chart on your left-hand side is looking at changes in positive menstruation attitudes, and this was measured on a scale. And the questions that constituted this scale included, for example, I feel ashamed of my body when I have my period. And what we saw is increased positive menstruation attitudes were increased significantly from baseline to endline by close to 1.4 points and 1.2 points in the combined and reproductive only arms, respectively. On the right-hand side, we can see it shows changes in gender norms. And again, gender norms, we asked questions such as girls are expected to be humble, or girls who argue with their friends in public do not behave as ladies. And what we saw is a significant increase in positive gender norms from baseline to endline, which is around just slightly over 1 point change point in the scales for the PADS and RH, and also for the RH only arm. Next slide, please. Again, we evaluated changes in equitable gender norms, and this was a 5-point scale. So here we were looking at sexual double standards, and we asked questions such as girls should be careful about the way they look, so they're not seen as being trying to seduce men. And again, what we saw on the left-hand side is a significant increase in equitable gender norms in both the PADS, the combined arm, and also the reproductive health only arm. And then in the right hand side, we measured self-efficacy using the general self-efficacy scale. And the questions we asked included, you always manage to solve difficult problems if you try hard enough. And again, we saw a significant increase in self-efficacy, particularly in the reproductive health only arm, which rose by 1.4 points. Next slide, please. Then we looked at sexual and reproductive health knowledge. We looked at pregnancy knowledge, which was a score out of 4. We saw that on the left-hand side, at endline, knowledge was at its highest in the combined arm, and this was significant. And we looked at STI knowledge, sexually transmitted infections, and we saw that there was a significant increase in knowledge in not just the PADS and reproductive health only arm, but also the reproductive health only arm. And this increased by over 1 point in the scale. Next slide, please. Finally, we also looked at educational outcomes. So we looked at number of school days attended, KCPE score. So KCPE is the end of primary school exams. And we also looked at the percentage enrolled in secondary school. And what we didn't see any significant changes across the arms in any of these indicators. Thank you. Next slide, please. So in summary, what we're learning is, at least from our study, that PADS did lead to improved menstrual hygiene management. We saw that reproductive health education led to improved sexual reproductive health knowledge, self-efficacy, gender norms, and attitudes on menstruation. But in addition, what we saw is that if you were able to combine both the reproductive health intervention with sanitary pad provision, then the effects on reducing shame and stigma around menstruation were significantly greater. And we didn't see any significant impacts on educational outcomes as a result of the intervention. And next slide, please. Thank you. And we'd just like to acknowledge all our partners in this study. Over to you, Karen.
Thank you, Beth and Nicole, for those presentation. Maybe you could both unmute yourselves or stay on video. We will have a bit of a question and answer period. So far, it seems like most of the questions are for Beth. So take a deep breath. First, there are a couple of questions around how school attendance data was collected. So could you provide a little bit more detail about that? What was the process like? Were there any random tests? Was there any validation? What kinds of registers were used, et cetera? So could you provide a little more insight on that process, please?
Thanks, Karen. So in school attendance, what we did is we went to the schools and took a register of all the girls who were enrolled into school at the beginning of term 3 of 2017. And then what we did is we used that as our, I guess, as you say, the baseline for the girls we were going to follow up. We also collected school attendance data for boys. So we had a register of enrollment for both boys and girls. So what we did is at the beginning of each of the terms, we came and took a register at the start of each day for 20 consecutive days. So this happened in term 3 of 2017, and then as the girls and boys transitioned to year 8, we also collected data for 20 consecutive days on term 1 and term 2. Yes, so that's how we collected it.
And sorry, so was it that you were relying on the school's registers, or there were independent data collectors coming?
Yes, so yeah, as you know, the school registers are not always complete or up to date. So what we did is we had our own data collection system where we had trained some data collectors from the community, and they would then come in at the start of each day to take the school registers. So that helped us to kind of ensure we had more robust data.
Thank you, Beth. And could you speak a little bit more about the process of getting approvals from the schools? So how did you get the schools to agree to participate? How did the parents, what was that process like?
Thanks, Karen. So maybe I can talk from the research side, and maybe when Megan also gives her presentation, she can also give some insights from the intervention component. But because this was a research study, obviously first we did need to get ethical approval from Nacosti and from the from AMREF, who we were using as the ethical scientific review board. And then when we went to the community, we engaged with the county government and carried out some community sensitization activities there to inform them about the project and also make them aware of the type of interventions we were planning to carry out. And we also used them to help us choose the schools we wanted to work in. And they also played the lead role in carrying out the randomization of which schools should go into which arm. And then from there, we then we also engaged with at the school levels and, introduced the project to the head teachers and to the key staff at the school. We also needed their engagement and their approval because we needed their cooperation in getting the girls to come and participate in the sessions. So we got the teachers on board, and also we carried out community awareness activities, so through parents associations from the school to inform the children, the parents to the children about what what the project was about, what we intend to teach the girls. So, you know, going through the topics on the curricula and getting approval. So even before we started data collection, we also went through the consenting process where we got consent from the parents themselves. And we also got assent from the girls themselves to be enrolled in the study. Yeah, hope that answers the question.
Thank you. Apologies, I'm having a little bit of internet. Can you hear me now? Okay.
Yes.
Great. So this is a question that could go either to Nicole or to Beth. There was somebody who was wondering if we had any data on the relationship between girls' menstruation experience, like cramps, on the overall school experience or absenteeism, if that came out at all, either in the review or in the particular NIA study.
I'm going to jump in quickly because my answer is very easy, no. We also didn't look at the review was strictly focused on, the systematic review was focused only on the outcomes. So we didn't look at other outcomes like that. Sorry.
And just quickly to respond, we did look at you know, other reasons for girls not attending school, and yes, pain caused as a result of menstruation was something that was mentioned, and it did come out in the interviews. However, I'm not sure if it was a significant outcome, but it was definitely mentioned.
Thanks. And I see there are, maybe we have time for one more question, and I'll ask Beth, there are several questions about the content of the curriculum, and I'm wondering if you want to answer that or if you want me to sort of take that time and shift it to Megan to respond.
Yeah, I think I'm happy for you to shift it to Megan, since ZanaAfrica did design the NIA Yetu and the curriculum.
Sure. So thank you very much, both to Beth and to Nicole, for really setting the sort of data and evidence stage and background and this webinar. And now I'm really delighted to shift the conversation and to welcome Megan White Mukuria from Zana. If you can turn on your camera. And just a lot of thanks both for your partnership over the last couple of years on this research project and for participating today, of course. So again, keep the questions coming. I have a few questions of my own for Megan, and then we'll leave some time as well for questions from the audience to come in. So Megan, just to give us a bit of context, and I will loop in the questions that came in during Beth's presentation, but maybe just let us know a little bit more about ZanaAfrica, you know, when you started, what are your goals, and then a little bit about sort of several questions about the content of the NIA curriculum, the NIA Teen and the NIA Yetu curriculum. So maybe you could share a bit more, some interest from the audience in that, and in particular also understanding sort of how the MHM was integrated into a broader RH education curriculum.
Awesome. Thank you so much. And Karen, it's wonderful because we've known each other for, I think, the better part of 20 years. And it's amazing to be on this other side of doing research to really build the support that girls and adolescents need to thrive. And that's really what ZanaAfrica is about. I've been in Kenya for the last 20 years and started ZanaAfrica in 2006 to address this dual need that I identified through working with former street children of both a lack of sanitary pads and also a lack of rights-based answers to help them safely navigate adolescence. There was a lot of insights around very early age of sexual debut, around the unwantedness of that, around power dynamics and things like that. And those are all things that we've been trying to address. So everything that we do is ZanaAfrica. We're a Kenyan headquartered organization. is co-created through listening. So we started out with this idea of pads and health education. Initially, we actually wanted to put information inside pad packages, and due to the limitation of that, we started to create more content. As we kept listening to girls, they wanted more and more. So we basically looked at what is the body of knowledge in terms of life skills, menstrual health, and related reproductive health that they need to know so that they can safely transition into adulthood and make their own informed decisions in line with their own values and such. And that kind of spun into this beautiful curriculum, which reimagines a textbook as a magazine. I'm going to hold up, this is the facilitated health curriculum that we created. And if anybody needs more information, we can definitely send you more. And Rupal will give her email in the chats before we end. But it's 5 modules that go through each term. So there's Welcome to Puberty. So that's about values, goals, adolescence and puberty, menstruation, menstrual health, kind of the nuts and bolts and physical component. There's Gender, about reproductive system, self-esteem, communication, introduction to gender and gender stereotypes. Then the 3rd term talks about gender and power and rights. So human rights, power dynamics, sexual violence and exploitation, how to report and avoid issues of sexual violence, being assertive in decision making. The second to last module is gender, power and rights again, more around healthy relationships, sexuality and behavior, teen pregnancies, STDs and HIV. And the last is being true to yourself, about managing stress, anger, conflict, drug abuse, and peer pressure. And so that is what we delivered in after school clubs that Beth and the Pop Council team reviewed. The paired magazines are really reinventing the textbook as a beautiful story-based, rigorous textbook, but really full of Kenyan stories. And we think that that's really in line with who we are as Zana. So that was what we tested, and that's kind of like the fullness of what we're wanting to achieve in Zana, is creating this solution that met a systemic need that's rather intersectional, that we can then scale up through other partners, government, international NGOs, others, et cetera. And so that's really what we're trying to do as Zana. Does that answer all of your questions? I think there are a bunch of questions there.
I think it gets yeah, and so take us a little bit on the journey of you've been working with girls, listening to girls, developing a program, and all of a sudden you decide, hey, let's do a randomized control trial. That'll be fun. I imagine nobody except for maybe us researchers sort of wake up thinking it'll be fun to do an RCT. So, what was it about data? How had you been using data before in Zana? What was the motivation to really essentially open yourself up to quite a rigorous evaluation, some manipulation of the intervention to match the research protocols? So
yeah,
what was going on in your mind?
And could go in so many directions. So, we've always been driven by data. I started this because I saw an unmet need and kept wanting to reevaluate, is this the right way? Is this the right way? At the time in 2006, I'd launched the National Sanitary Towels Campaign in partnership with the Ministry of Education, and Kenya has always been a leader in menstrual health, and it's been unprecedented in a wonderful way to be here at this time and to help facilitate these kind of shifts. But that really, that wasn't enough to just kind of launch that and think that everything was fine. So I kept trying to find out more about what was the state of the state for girls. I had a lot of qualitative data in early days, right? We'd see schools that other community-based organizations were working with. And there seemed to be this disconnect between everybody saying girls miss school when they don't have pads. And some of these early quantitative studies that were coming out, they were saying maybe that's not the case. And in the early days, we really had to say, pads keep girls in school, because menstrual health wasn't even on the radar. It's still really not on the radar in any of these development silos, right? It's not really in sexual and reproductive health and rights. It's not really in global health. It's not really in education. And so it slips through all these cracks. So we were committed to creating data to drive this agenda of awareness globally, And so we did a lot of work. I did a lot of work with the Gates Foundation, Grand Challenges Canada, to really help them understand the severity of this issue and the fact that half the population, roughly, menstruates at any, point for a long period of time in their lives and needs support in this, and that it's a critical gap. And so they kept asking for more data. So we kept saying, okay, can you fund it, please? So we got to the point where we had a lot of compelling evidence that we were in the right direction. And I was really honored that the Gates Foundation selected us to be getting a fourth grant from them, which was the last one we've gotten so far in the Putting Women and Girls at the Center of Development, which was Melinda Gates's Grand Challenge. And so this gave us this beautiful 4-year moment to really put together all these pieces that we'd seen and to test it out independently, which is so important, because a lot of the data, if you get it and it's just you can tear it apart in a million ways. And we've seen that so much work has been done in data that Nicole shared, but so little is necessarily maybe contributing to moving the framework forward. And that's a real problem, right? So we'd known Pop Council for a long time. You guys are really outstanding in the quality of your work and in your focus. So there's real alignment there. And I'm really glad that worked out, and with Plan International to run it. So, it really all started with us listening. We started with 10,000 questions for girls, and then we built that up into this curriculum. So mapping the girls' questions that we got all across the country. And we have boys' questions too, and this is a boys program, but the RCT component was only for girls. And then mapping out the best-in-class programs out there for life skills and reproductive health education, filling in a really critical missing gap that we saw of gender and power, aligning the human rights framework, aligning the values framework, and then testing it out. So everything was co-created with the communities. And so I think that that's what made it so powerful. But, I spent the better part of the last 20 years working on this issue, right? And I don't want to work on this issue if it's not really what girls need, right? But if this is what they need and they cannot advocate for themselves. And I think we'll speak later about some really exciting results that even surprised me that have opened up, I think, a real opportunity to replace this narrative of pads keep girls in school, to still keep pads and health education out there, but maybe in some surprising ways.
Thanks. And I mean, I think I just want to pause and say a real big credit to ZanaAfrica for almost like pausing for those 4 years, not pausing, but really taking 4 years is a long time in the life, especially of a young social enterprise, to really invest in that rigorous research. And I think, continuing along what you were about to start saying, so we now know the results of the study. Beth presented them. What was that like, sort of hearing those results, pondering them a bit, and then, so it would be great to hear your reflections and how you, and not just you, but also the Zana team in general, you have staff in Nairobi, there was a whole team in Kilifi running the intervention. What was surprising, and what did you do with that? And so continue on the journey of Zana. So you're listening to these results, what are you thinking? And now what are you doing with them in the years since?
Yeah, so I love looking at data. I think you guys actually created the largest database of attendance, like on the continent or something ridiculous like that. You can clarify, but I love contributing to this like ability to analyze and evaluate and find maybe nuances that we didn't recognize. So I wasn't particularly surprised. I think our team was particularly surprised that attendance was not top of the list. We've known that absenteeism, specifically due to poverty, going out and needing to get water, illness for waterborne diseases or other things like that, inability to access medical intervention in time. Like these are things that are bigger drivers, as well as getting kicked out of school for lack of school fees and such. So that wasn't surprising to us, but I think it really is surprising to the world of menstrual management, who has been trying to fundraise on this narrative of pads keep girls in school. And the thing is, I think that does a disservice to pads and does a disservice to girls, because it shouldn't be linked to their educational outcomes, in my opinion. we have a right to manage our bodies with dignity. And even just last year, the UN recognized menstrual management as a human right, just like the right to water. And so this is really important that we, as humans, allow people to access their full human rights and their full health rights, right? So from just that perspective, it's important enough. It shouldn't have to be only provided if girls do better because of them, and otherwise, like, they're on their own. Good luck with your bleeding 4 to 6 days a month or more, right? I mean, we've walked into so many schools where there's literally bloody tissue on the ground and nobody wants to pick it up and nobody wants to mention that it was theirs because girls just don't have the tools. What was surprising in a wonderful sense was we knew we were trying to challenge social norms. But what I really see from this data is that it says that when you provide pads to girls, it helps to open up these conversations, because everything has been driven about with them asking their own questions, right? Even at the end of every session, they can write down anonymous questions and they get answered at the next session. That they have the right to ask these questions, and they have a space to answer these questions or get them answered. And then combining that with the experiential challenging of those norms, right? Telling a girl, actually, you can play sports, even though culturally your society is telling you you can't. Here, have some pads, go play sports. Then the world doesn't end, and actually she feels fulfilled. Maybe her menstrual cramps are actually reduced. She's happy. Now she kind of, it's almost like The Matrix for those who know the American movie. I think a new one just came out, right? Where they're seeing that there's this alternative reality and their reality is shaped by social norms, and maybe some of them are not positive. Maybe some of them are actually not aligned with these human rights, and we can actually challenge that. So maybe if I'm a girl and my mother is being hit by my father or my stepfather, I can actually recognize that that's not okay in a country where almost half of everybody thinks that that's okay in certain circumstances, right? And so I think that that is the key success that's creating this domino effect in a positive way for challenging other social norms. So I was really excited to see that we were changing these very entrenched social norms in just 18 months, because that is incredibly hard to do. And I think it speaks to our team really understanding our end beneficiaries and working at this with them and with their communities and with the government, so that we're all kind of moving in that direction. And so, you know, I think it says it's necessary, but it's not sufficient, right? We've talked with Pop Council and your president around the cash transfers, right? So what would this look like to pair with cash transfers to address some of these problems that Nicole also highlighted? Because it is necessary, and it is, but I would like to see it shifted into sexual and reproductive health and rights globally. So it's like MSRHR, menstrual, sexual and reproductive health and rights, and it's like in that docket, so we're all thinking about that, and that it's seen as a shifter for social norms at this really important time for both boys and girls. And I can speak a little bit to some data with boys at the right time in this conversation. Yeah.
Thanks, Megan. And I appreciate you bringing it back to the review that Nicole shared, is that, you know, when we're thinking about girls' education, the types of gendered barriers are vast, right? Like, I think there were 18 on there. And so, you know, menstrual hygiene management has a key role to play, but if, you know, the challenges that face girls, there are a myriad of them. And I think it takes sort of all of us working together, thinking about how do we address these different barriers, MHM included. So thank you for that. I saw a question from the audience, and then maybe you can also use that to tell us a little bit, like, what are you doing now with these results? And there was one question about, has this curriculum been adapted elsewhere? Are you using it elsewhere? So maybe you can start by answering that and tell us a little bit more about what's going on. What have you been up to since these results have come out?
Yeah. So we're so glad the results came out, because with COVID, it got postponed a very long time. So thank all of you on this call for waiting with us and joining us here. That was no joke. Yeah, so it's been exciting. We immediately, as even we were doing the randomized control trial, we caught the eyes of World Vision, and World Vision Canada, or World Vision Korea, I can't remember which one, initiated a partnership with us where we trained 40 teachers, through TSC, the Teacher Service Commission, and 3 Teacher Service Commission curriculum officers on the curriculum in Western Kenya in the sub-county of Engerai. And that was amazing. We learned a lot about, we were doing the intervention through Plan International with young community health volunteers who already had the whole framework of rights-based and reproductive health education and all of that. So working with teachers, we really found that teachers carry a lot of trauma of their own, a lot of that around the impact of these negative and harmful social norms on their own lives, such as rape, such as spousal abuse, such as menstrual health shame, and things like that. And so it's really helped us to think more deeply about adult learning and to think about incorporating a trauma-informed lens into this work to really help the adults in youth lives to show up for themselves and for the youth. So we've been working in 86 community-based organizations looking around trauma-informed work, and have been talking now with Kenya Institute of Curriculum Development and Teacher Service Commission and the Ministry of Education around co-creating this into the new CBC curriculum. So those have been some very robust conversations. There's some amazing leaders in all these different government organizations who are really seeking out positive solutions that have measurable results. And I think that there's not enough of those. So we are looking at formally presenting a revised version to KICD for approval in the 844 system and with others as we look to scale. So looking at a potential trainers of trainers model for other CBOs, INGOs, et cetera. And then really working with the government to incorporate this right now, looking towards secondary school, because that's where they're evaluating their matrices and such, but then figuring out how to cascade that down. And it's given us some real expertise in social and behavior change communication that I showed you, the comics and the magazines and whatnot, that can be applied to understanding how to help youth have greater knowledge retention. So I think that that's been really amazing. We did the program with boys as well, and so I wanted to speak to that for a moment. We started in, after the RCT ended in 2020, we started with a cohort of 10 schools in Kilifi. And it was tremendous how essentially how social norms negatively affect boys too, right? Especially gender norms, and the sense of toxic masculinity, the sense of putting a girl in a box, how that limits boys too. So for example, in boys that weren't in our cohorts, when we'd ask them, are girls supposed to be the only ones to do chores, essentially, better framed than that. If they weren't in our cohorts, they would say, like, of course, God created girls to do this work. What are you talking about? Which is problematic on a number of levels, right? I'm assuming all of us would agree on that. And afterwards, going through our program, they would say, of course, we would help step up and work with girls. Like, girls shouldn't have to bear this burden alone. Like, these are household chores. The household has to chip in. So reframing that toxic masculinity, reframing that equity and equality is going to be a real win for everybody, right? And so we're really excited to integrate this into various different curricula out there so that boys and girls can kind of go through this rite of passage and come out the other end safe and informed. And the last piece that I'll mention is that we all know what a detrimental effect COVID had on girls and how much dropout there was, as well as for boys. Like, there's a huge dropout for boys because they needed to step up and work to bring in money at the household level. And again, this is qualitative, not quantitative, but in the schools that we were in Kilifi, even though they'd only done 3 out of the 5 modules or 4 out of 5 modules, all of the girls came back and they weren't pregnant. And like the boys came back too. And so I would really be interested in seeing more longitudinal studies, particularly even of this cohort that we spent so much time investing in. I would love to see whether or not they were able to matriculate into secondary school. How have they been better able, if at all, to navigate the difficulties that life throws them? Because I think that that's a really important kind of next step for the research.
Thanks so much, Megan. I was going to ask you a closing question around if there was one more sort of data point that you wanted to see, what would it be? But you've already answered it in terms of having longer term follow-up and really understanding even longer term effects of the program, which I would definitely agree. We had more questions, and I'm sorry we couldn't get to everyone, but I do want to keep to time, so I'm just gonna wrap it up. Just a few takeaways and reflections. So one is that really reflecting on this point that the barriers to girls' education are multiple. They're often structural. Somebody on the audience made that point. I think it's very important, and that we can't really expect PADS to solve all of that. But at the same time, we can really think about PADS as a right for girls, and that it's our responsibility to integrate that into broader reproductive health education. And just sort of a final reflection on, I really appreciate this example and the way that everything coming together today, thinking about sort of the value of partnerships in data and evidence-based programming and policy. And, you know, really having an example here about how researchers worked with implementers who are now working with the government to really take sort of a robust body of evidence generated to really do the best that we can for girls. And I think that's really encapsulates our mission here at the Girls Center well. So I want to once again thank all of our presenters and panelists, and of course all of you in the audience for joining our webinar today. We invite you to explore the global systematic review that Nicole presented, and the Kenyan study of the NIA trial to look closer at the evidence. The links are up on the screen. And I believe in the chat as well. And we also invite you, and also please check out the ZanaAfrica website to learn more about their work. And we invite you to subscribe to the quarterly Girls Center newsletter and EGER's quarterly digest to stay informed of the latest research and news. You can find all of these links to these resources in the chat. And we're going to follow up with all of you next week to share a recording of today's webinar, as well as the presentations and resources. So again, thank you so much for joining us, and goodbye to all of you.